On behalf of the School of Global Public Health, I'm really thrilled to welcome you all to New York University. I'm Deborah Furr-Holden. I'm the relatively new, I guess I can do that for about maybe a year or so. It's been about 4.5 months. I'm the new dean of the NYU School of Global Public Health. And it's a personal privilege to see you here. And I know there are also people online that are joining us for our 6th annual William C. Steubing Memorial Lecture. This is the first time we're gathering in person since COVID. Since COVID, since 2022. So really, thank you all for joining us. Our lecture tonight, which I love the title, Are Robots Racist? Right? Lecture over, we got our answer. Rethinking automation and inequity in healthcare. It's both timely and it's important. And now it's my honor to introduce our partner in this annual lecture, a leading national institution working to expand bioethics knowledge and to improve clinical, biomedical, and public health decision-making, policy, and practice, the Greenwell Foundation. The Greenwall Foundation. This is a problem when you're a dean, you run from thing to thing to thing. I'm normally really good at this, but I'm trying to get it right, so thanks for bearing with me. Greenwall's board chair, Dr. James Tulsky, is the chair of the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Cancer Institute and chief of the Division of Palliative Medicine at Brigham and Women's Hospital, and a professor of medicine and co-director of the Center for Palliative Care at Harvard Medical School. Please join me in a warm NYU welcome to Dr. James Tulsky.
Thank you so much, Dean Furr-Holden. We are so grateful to the NYU School of Global Public Health for joining us once again in hosting the annual William C. Steubing Memorial Lecture. I'd like to talk a little bit about Bill Steubing, about whom this lecture was named. Bill Steubing served as president of the Greenwell Foundation for more than 20 years and passed away in 2015. Under his leadership, the foundation developed its focus on bioethics and became the primary private funder of this upstart and critically important field. He particularly understood that bioethics needed a pipeline of talent, and he oversaw the creation of an interdisciplinary bioethics fellowship program at Johns Hopkins and Georgetown, as well as the Greenwell Faculty Scholars Program, which remains our flagship investment. Graduates of these programs are among the most important voices in current bioethics deliberation. Bill was a study in contrasts, and among the most unique people I've known. He was an ordained Lutheran minister, an educator, who first served as a headmaster of a parochial school, and later turned his professional career toward medicine, ethics, and the arts. Although traditional and quite elegant in dress and style, Bill relished radical ideas, regularly took risks, and as a funder sought out controversial, important work from which others shied away. Under his oversight, the Greenwell Foundation was among the first to support bioethics research on topics such as organ transplantation from non-heart-beating donors, the influence of big pharma, and genetic engineering. To know Bill was to experience a deep thinker and with a kind and generous heart. He was intensely curious, and given his eclectic background, he loved to find connections between art and medicine and theology and science. And more than anything else, he relished gourmet cuisine seasoned with witty, smart, and thought-provoking dialogue.
I know that's right.
The Greenwell Foundation's hope for the William C. Steubing Memorial Lecture is to model and promote vigorous and civil discourse on bioethics issues that might otherwise escape the public eye. This evening's topic is exactly that sort of conversation. We miss Bill tremendously. I'm glad that we're joined today by his husband and life partner, Ron Thomas. I'm privileged to now invite Michelle Groman, the president and CEO of the Greenwell Foundation, to introduce this evening's program.
got another short person up here. Let me first add my welcome to this year's William C. Stubing Memorial Lecture. To those of you in the room, and of course, all of you joining us online. I'm really thrilled to be back here in person in New York at NYU, while also able to reach a wider audience, broadcasting live as part of our first hybrid William C. Stubing Memorial Lecture. I also want to extend my thanks to the NYU School of Global Public Health and Center for Bioethics for partnering with us for this event. At the Greenwald Foundation, we seek to make bioethics integral to decisions in healthcare, policy, and research. Earlier this year, we launched 2 strategic priorities: shaping and supporting a broad, inclusive bioethics, and increasing bioethics' impact on policymaking. This evening's conversation on ethical issues at the intersection of healthcare, artificial intelligence, and race will address these priorities head-on, not only diagnosing the situation as it currently stands, but charting a path forward toward greater equity, greater justice. Now, a few quick housekeeping notes before we begin. We'll have 20 minutes for questions from the audience at the close of our moderated conversation, and we'll read out as many as we're able. If you are in the room, we have cards to write your questions on available at the registration desk. You can pass them forward to me or hand them to one of our staff members. Could staff quickly wave so you know who they are? Thank you. If you're watching online, there's a link underneath the webcast player to submit a question. We will also be live tweeting today's discussion. You can join the conversation using hashtag Stubing2022. The webcast video is closed captioned, and we will be recording today's discussion and sharing it following the event. We'll send a link to those who registered, and you can find it on NYU's YouTube channel and the Greenwald Foundation's webpage. I'm now pleased to introduce today's moderator, Meghna Chakrabarty. She is the host of WBUR's On Point and a fixture in award-winning public radio programming over the years. This May, she hosted a 4-part series called Smarter Health: Artificial Intelligence and the Future of American Healthcare, beginning a conversation on some of the topics we're diving in more deeply this evening. Meghna, I turn the stage over to you.
Thank you, Michelle. Thank you to the Greenwald Foundation for inviting me to be a part of this conversation. It is my distinct pleasure to introduce to you tonight Dr. Ruha Benjamin. She is an enthralling storyteller, a professor of African American Studies at Princeton University, where she studies the social dimensions of science, medicine, and technology with a focus on the relationship between innovation and inequity, knowledge and power, race and citizenship, and health and justice. As the founding director of the Ida B. Wells Just Data Lab, she brings together students, educators, activists, and artists to rethink and retool data for justice. Dr. Benjamin is the author of Race After Technology: Abolitionist Tools for the New Jim Code, editor of Captivating Technology, and she recently released her 4th book. I don't know where you find the time, but Viral Justice: How We Grow the World We Want. And it was born out of the twin plagues of COVID-19 and police violence. And at the center of all of Dr. Benjamin's work is the invitation to imagine and craft the worlds we cannot live without, just as we dismantle the ones we cannot live within. Please join me to welcome Dr. Ruha Benjamin. I have always been deeply fascinated with technology. I come from a family of scientists and doctors and engineers, and it became more apparent to me over time that the ways that we all see technology impacting our lives is only the smallest fraction of how it actually is. So that's what got us interested on our show, to really take a look at AI in general. But we decided to focus on healthcare because it's something that touches everyone. And what I discovered, what I learned from the outside looking in was astonishing and shocking. But before we get to what's happening now, Dr. Benjamin, I wondered if you could walk us through what we need to know about what has already come, about the promises and perils, promises and pitfalls of AI in healthcare, so that it gives us some grounding to understand the issues today.
Yeah, thank you for that. Hi, everyone. It's good to see you. Thank you for coming out on this drizzly day. Thanks for everyone tuning in. It's such an honor to be invited to be in conversation on this important topic, and I appreciate that starting question because it starts us out not focusing narrowly on the technology, but on the social context in which technology is developed. And I should say at the outset that I am trained as a sociologist. I work in a Black Studies department. And so my approach to these questions is necessarily shaped by my disciplinary training and my preoccupations in these fields. And so I say that also if you have questions about law and other things, we're here in law school, public health, I may sort of defer to others and draw on other people's work to help us think through these. So as a starting point, I like to begin by provoking us to think about how we imagine the relationship between technology and society. And in my view, there are two dominant stories that we tell and are told about this relationship. The first story is what we might call the techno-dystopian narrative, that technology is going to ruin us. It's going to wreak havoc, whether it's in the context of work and take all the jobs. It's going to rob us of our human agency. Everything bad is associated with technology. And this is really the narrative that Hollywood loves to sell us in the form of the Terminator, the Matrix, the list goes on. The other story is what we might call the techno-utopian narrative, that technology is going to save us. It's going to make everything more efficient, more fair. If only we would hand over major human decisions to automated systems, we would be able to even bypass human bias. And so this is, of course, the narrative that Silicon Valley loves to sell us and has marketing teams working 24 hours a day, 7 days a week in order to sell us. And although these seem like opposing narratives, they have different endings, right? One in which we're helped, one in which we're harmed, one in which we're saved, one in which we're slayed. They actually share an underlying logic, what we might call a deterministic logic, that technology is in the driver's seat. It shapes us, it impacts us. But the human agents and agencies behind the screens are missing from the scripts. And so as a starting point, one of the first things we have to do is pull back the screen and think about what's actually animating our socio-technical systems. What are the values? What are the ideologies? What are the incentives? And when we begin to do that, I come to a second provocation, specific to AI, what we might call deep learning as a method within this broader umbrella of AI. And the provocation is this, that computational depth without social and historical depth is actually superficial learning. So I'll just say that again as a provocation. Computational depth without social and historical depth is superficial learning. That is, we shouldn't be surprised then if we find day after day a new headline about racist and sexist robots, about these little tools that we're building, reproducing and reflecting the social inequities that permeate our society, because those who are doing the designing are not bringing a wider tool set to the table. Not necessarily out of any kind of malicious intent to harm, but because a kind of awareness, a social consciousness, a racial consciousness about the history and sociality in which they're developing these tools is missing from what they're doing. And so the last thing I'll just say, just to whet your appetite in terms of what that might entail when we're talking about healthcare in particular. Medicine and science has in many ways aided and abetted white supremacy and racism and inequity. It doesn't stand outside of these as apolitical or asocial. And there's so many specific examples that I could illustrate this point with for those who need evidence. And we should all demand evidence. But I'll just put two names out there that are sort of touchstones for me in terms of the complicity of science and medicine in terms of these larger systems of oppression. One name is Georges Cuvier, French naturalist, renowned figure of his time, lived between late 1700s to the mid 1800s. If he lived today, he would get all the NIH money. He would probably be a MacArthur Fellow, big name guy, not fringe scientist. but also a figure that helped to create the racial taxonomies that we take for granted today. I imagine us living in a kind of racist house, a racist architecture. And scientists like Cuvier helped to erect this architecture through what they published, to how they named the world. And what's interesting in terms of his own story is that his student, Frederick Tiedemann, who initially came to sit at his feet and learn from him, turned on him and began to refute the racist biases associated with his work and the scientific fallacies. And so I say that to say, just to put this out here, that even as we're sort of tracing a dominant sort of trend of scientific racism, there have always been individuals and groups and movements that have refuted that dominant narrative. And that's also a tradition, an anti-racist tradition that we can build on today. We're not starting from scratch. We're not imposing our progressive values on the past, but we're building on the work of Tiedemann and others. I guess the last thing I'll say in terms of pulling back the screen and getting us to think in terms of the social and historical context in which AI is being developed is that there are a lot of buzzwords associated with AI and with emerging technologies more broadly. And I think we have to move beyond the buzzwords and really think about what these tools are doing in the world. One buzzword that's often associated with AI is precision medicine. That it's allowing us to go from a kind of one-size-fits-all to targeted precision medicine. But in terms of the history of precision medicine, racism has often informed how these tools have been wielded against different groups. The precision has often been in terms of naming Black inferiority, in terms of Black physiology as inferior, and then creating what's called race correction or race norming to be more precise for different groups, whether it's in terms of kidney function or lung capacity. Some of you may follow the recent NFL case that had to do with neuropsychological function, in which Black players were presumed to have a lower starting cognitive function as compared to white players, and so it took them more to qualify for the concussion settlements. And so this legacy of scientific racism and racial taxonomy still is like some people call it the ghost in the machine. It still informs how medicine and healthcare are practiced today. And so these are just some of the things, we can get into it more, that I think we have to bear in mind, that we're not just analyzing isolated tools and instruments, but the context that produces them and in which they operate. So I'll stop for now just to, again, to remind you that I'm approaching this as a sociologist, as a Black studies scholar, and so the way that I'm thinking about it, the questions I ask, the context that I'm bringing to bear on this are informed by that background.
No, this is very important background because then it helps make sense of some of the technologies that we already know are out there and what their impacts are. In 2019, there was a paper, you know it well because you wrote a commentary about it, published by Dr. Zaid Obermeyer and his colleagues. And for those of you who don't know this paper, I'm just going to summarize it really quickly, because when I just only recently read it earlier this year, I had to read it several times because I actually couldn't believe it. I mean, shamefully, I couldn't believe it, but because it's quite something. So basically, as you probably know, large health systems and payers, that's a key part of this, rely on, there's an algorithm or algorithms out there to target patients for high-risk care management. And these programs, their goal is to improve the care of patients that have complex health needs by providing additional resources, including greater attention from providers, and to help ensure that care is better coordinated. But how do they do that? How do these algorithms do this? That basically the tool is designed to predict the cost of care, okay, as a proxy for healthcare needs. So superficially, that kind of makes sense. But what Obermeyer et al. Discovered is that Black patients with the same risk score as white patients were in reality, so their risk scores were the same, but in reality they were actually much sicker because providers spend less on Black patients, okay? And so this algorithm is in use for hundreds of millions of Americans, basically everyone. It's already out there. Payers are using this. So what are the implications?
Yeah, so, I think there's so many interesting ways to unpack this study. One is just to take note that it was a race-neutral algorithm, meaning that race was not explicitly accounted for in the development and implementation of this. And so the cost of care became this proxy. And so what's interesting to me is that we assume that race is an inherent quality of individuals rather than a feature of our systems. So what I mean is that even though they controlled for race, they took race out of the equation, they didn't keep in mind that race was shaping everything about healthcare, including the cost of care. So you can remove it explicitly as a quality of individuals and ignore the fact that it's shaping everything else, all the other variables that they're measuring. So that's one thing to bear in mind, is that colorblind healthcare is not the antidote to racist robots. So we don't want to ignore race and racism. We want to think about how it's infecting our society, our social relations, and then if the goal, I'm not saying that's my goal, but if the goal is to create instruments to predict X, Y, and Z, we need to think in a more complex way about how race is shaping the context. It's not simply a quality of individuals that we can control and take out. The other thing to keep in mind about this entire context is that even if there were not racial disparities as we found here, something that's important, I think, to put on the table is that our country spends much more on healthcare than other developed nations, and we have the worst outcomes. So even if there weren't these disparities, we have to think about the overall investment and what we're pouring money into, and why our overall outcomes, why we have much higher rates of chronic disease, premature death, a whole host of factors where our outcomes are worse, even though we're pouring so much money and investment in this. And so I'm just going to put that out there as something just for us to wrestle with as part of the socioeconomic context in which an algorithm like this is, the intention is to save money, to target those patients who most need care so that we're not sort of distributing across the board. But yet we need to peel back the screen and really think about how where these investments are going overall.
Yeah. I mean, that's why your phrase, the new Jim Code, is very compelling to me, because in your words, automated systems hide, speed, and deepen racial discrimination behind this veneer of technical neutrality. And that raises the question of, like, going very, very, very deep into the process, to the very first steps when, before even a line of code is written. Because one of the takeaways from the Obermeyer study was that, he said, the medical world and healthcare wants an algorithm to figure out who's going to get sick, but what was this algorithm actually doing? It was confusing high cost with high need. And the reason why I raised that is just to give folks another quick example. At Stanford Medical Center, we talked to some developers of AI there, and they have already launched at Stanford Medical Center a program that, no matter who you are, if you get admitted to the hospital there, whether it's for like tonsillitis or multi-organ failure, everything in between, this tool analyzes your medical records and gives your care providers a prediction of your probability of dying within 1 year, no matter who you are. Now, the purpose of the algorithm is to help advance end-of-life care conversations between a care team and a patient. But what is the algorithm actually looking at? Who might die? So it's actually, these are two different questions. And the reason why I wanted to identify that is because you've written about even just how basic labels are important in, again, bringing the cultural, sociological context into the fundamental development of what questions are we even asking the technology to answer?
Yeah, absolutely. I think for me, when people ask, okay, so now what? What do we do? Where do we start? It always begins with posing the problem. Whose questions are we following? Because then that kind of has a ripple effect in terms of then what data do we collect? What are we training the algorithm on? It's a sort of a rabbit hole. And so I think in terms of the effective use of these technologies, one of the things that excites me is when they can be used to cast and shine a light on existing forms of inequity and disparity, where things that we kind of knew intuitively or saw in terms of sort of anecdotal examples, when they shine a light on the existence of these disparities. And so it's a way of retraining the digital tools. And so I know of examples in the context of finance, the context of the criminal justice system, where rather than measure and predict the riskiness of individuals in these contexts, the tool is trained to look at how risk is produced by those in power. And so rather than on someone who's standing trial or measuring recidivism, it looks at judges' decisions and how likely they are to make a decision that's non-constitutional. Or in the context of finance, rather than look at so-called street crime, there's an interesting app created by an artist called the White Collar Early Warning System, the White Collar Crime Early Warning System. You can download it on your phone now and pull up a heat map and see in the city of New York the likelihood of where white collar crimes are likely to occur. So these are tools that are reminding us that who is often developing these tools shapes how the problem is posed, who is considered the problem, where risk resides. And these projects are turning the lens back and saying, well, let's look at who's producing the problems that often go invisible. Another one I'll just throw out there in the context of housing, where you have often looking at tenants and those who are most vulnerable in our real estate markets. It's called the Anti-Eviction Mapping Project, that looks at landlords and looks at real estate developers and maps data based on their likelihood to evict illegally. And so in this way, I think digital tools can be effective in terms of turning the lens back onto power. And it matters the questions we pose, how we're labeling the world, and because it sends us down certain rabbit holes and it makes us ignore certain questions and problems at the same time.
Right. That's an excellent point, because the focus traditionally is on the receiving end of that power. A point well taken. I do want to spend quite a bit of time talking with you more about ways forward, but before we do that, just kind of a fundamental here. I mean, it's well established, you've talked about it in detail already, about the biases already in the healthcare system. Mm-hmm. Everything from, again, how payments are made, to how hospitals as systems treat patients, to what happens in the doctor's office. Is there a place for machine learning, for AI to be a force to, in a sense, to put it bluntly, actually make better decisions than doctors do sometimes?
Yeah, there's a really great study that I think of when a question like this is posed by some of the same team members on the first healthcare algorithm study we were talking about, Obermeyer and colleagues. And what they did was they acknowledged, looking at the mounds of social science data that show these biases exist, in particular around pain treatment. The fact that medical students and doctors routinely underestimate and undertreat Black pain for a variety of reasons. And so they said, well, if we train the AI based on doctors' reports of pain, it's likely going to reproduce this existing bias and overlook the real pain of Black patients. And so what they did was they trained the algorithm not based on doctors' reports, but on patients' self-reports of pain, and found that it was both less biased and more accurate. And so here's an example of a team of designers actually incorporating the social science and incorporating the data on bias and saying, let that inform our approach to design, and it actually being more effective in the end. And so I think that more of that is welcome.
But it requires that rigorous questioning of what are we actually trying to achieve here, rather than what seems to be the common paradigm of technology, but really AI specifically, that like there's a problem, however we define that problem, and tech is going to solve it, right? So I mean, you're asking for a real rethinking of what this paradigm should be. So with that in mind, again, moving towards like, what can we do about here? Give me a second to set up something, because it sets up a beautiful piece of writing from you. I just want to re-emphasize the obvious, right? That race is a correlate to social determinants of health, right? There's nothing inherent about black skin that should determine a person's health outcomes, but it's really, the correlate is how society treats people with black skin in particular. So you asked a critical question in a recent paper. With that sort of social truth in mind, you asked, what if new technologies sold to solve social problems are simply ill-suited for the complexity of the environments where they are being introduced? Okay? Very, very important question. So with that in mind, what other ideas need to be part of the process? What other ideas must we all be engaging with to create solutions that match the complexity of the environments they're being launched in?
Yeah. Fortunately, we're living at a time when awareness and intention to address these issues is really growing. And so, but we're still in the early days, really. A lot of the things that we're talking about tonight, although it's becoming a kind of general common sense, like the average person on the street now, I feel like if you said algorithmic bias, they would kind of know, oh, the targeted ads on my Facebook, you know, or, you know, there's a growing awareness, what some people call it the tech lash, that came from a few big scandals around technology. And so there's awareness growing around this. But I think in the context of healthcare, there are some really important frameworks. I think of them as conceptual tools that are being implemented that can inform this particular arena. Two that come to mind are structural competency. It's a framework developed by Helena Hansen at NYU and Jonathan Metzl. And what this framework is doing as part of the pedagogy and the research design process is to say that what we need to pay attention to are the social determinants of health. When we think about various disparities that exist, what are the factors in terms of the social, society, economics, politics that get under our skin, that enter our bloodstream, that create premature death? And so if you go to their website, structuralcompetency.org, they lay out a handbook, they lay out approaches to research design and pedagogy that I think can be adapted to thinking about algorithms. And so they're thinking about it in a very broad sense, but I think it's applicable here, getting us to think about what factors we need to include in our analysis. The other is a bit different but related. It's called cultural humility. It's developed by a physician out in Oakland, Melanie Tervalon. And what she does is she say, a lot of times when we talk about culture in healthcare, we're focused on patient's culture as a factor, a set of traits that supposedly shapes health behavior. And what cultural humility does, it flips the gaze again and says, rather than fixate on the supposed cultural differences of patients, which may play a role but often are very stereotypical, let's look at the values, the cultures that practitioners are bringing to bear in clinical interactions. What are the things in our own heads, the assumptions that we're making about people, the things that we value or don't value that might be distorting those interactions, that may be leading to, let's say, what we talked about earlier, how the cost of care is up or down for certain patients. So in some ways, these two concepts are part of the toolkit that I suggest that we hone and develop and think about how we apply in the context of AI, but in healthcare more broadly. So structural competency and cultural humility are two among many, and we can talk about perhaps how some research teams are putting these into practice.
Oh, I'd love to hear that. I'm very much a give me some
okay,
examples
all right.
person.
So one really great project, again, relatively new. So it's still in the learning phases about how this is affecting outcomes. Comes from Brigham and Women's Hospital in Boston. So this team of researchers, what they did was they looked at 10 years of data in their cardiology outcomes and found that black patients had much worse outcomes overall. And they isolated one of the mechanisms that when patients come to the hospital, white patients on average are directed to the cardiology service instead of the general service more often. And the outcomes in the specialized service are better overall. And so they wanted to figure out, you know, how they could intervene in this practice and trying to figure out what's causing it. One hypothesis is that white patients tended to advocate for themselves more readily That was one of the ideas. And so one of the things they have put into practice over the last couple of years is a kind of advisory, an alert, when a patient is admitted, that if the physician is about to direct them to general service, this advisory invites them to consider sending them to the cardiology service unless there's an overall consensus that they shouldn't go, and points out that there is this disparity that exists. So it's like an automatic alert to this data that says maybe you should think twice about why you're not sending them to cardiology. And so since this has been implemented, overall the outcomes have started to improve. It's for both Black and Latinx patients that they found the disparity, and for which this advisory has been implemented and is being rolled out. But one of the things I want to point out is that this particular intervention, which is pretty low tech, it's not a very complex AI system, but it's under this larger framework of what they call the Healing Arc campaign, ARC, and that's an acronym that I can't remember the exact terms for right now. But what's important to note is that that technical intervention is only one part of this larger framework, which includes what I think of as perhaps even more important, which is a commitment to build relationships with community members and what they call wisdom councils, which is the partnerships between community and the institution to really think about what a reparative approach to healthcare racism can look like and should look like. And so I throw that out there to say that when we're thinking about the way forward, technology can play a role, but we really have to take seriously the social infrastructure, the social relationships that are either being neglected and that should be established and fostered, that are part of any way forward. And I think this Healing Arc initiative at Brigham and Women's takes that seriously. That is, they don't just have this automated advisory set up in the electronic health record, but they're building relationships with community members to guide the entire initiative. And as they're working on rolling this out nationally in other places as well, I don't want that to get lost, is that sense of partnership with those who are most adversely affected by the status quo is essential to what they're doing.
Yeah. You know, I actually have the language of the exact alert that pops up, because it really does say, so on the EHR, the electronic health record, if, as you said, if the physician selects general internal medicine versus cardiology service, it says, the pop-up is, patient is from a racial or ethnic group with historically inequitable access to the cardiology service. Consider changing admission to cardiology unless extreme census or overriding clinical reasons for general medicine service. What I like about it, as just to reiterate what you're saying, is that it's not only it's not an alert simply for how that doctor's treating the patient, that individual patient, but it's an alert about how the doctor's decision-making plays into this larger system that we have, the inequitable system we have overall. I'm not aware of any other tool that does that. I mean,
this is pretty new, but it also got a lot of backlash when it came to light. And so it's a relatively new, lowish tech intervention that's about educating, again, remember cultural humility. It's educating the physician about this study that's happened and this larger history, and saying you have, rethink your choice. It still leaves discretion, but it's, I think, an interesting model for us to think about who needs to learn what. Oftentimes we talk about scientific literacy for the public, and we ignore the social and historical literacy that's needed for the so-called experts in any domain.
Yeah. So the team and the professional, or the people who developed the Healing Arc that's in place at the Brigham, they actively said they want to create a race-conscious model. This gets us back to what the race neutralizing you were talking about earlier. I mean, do you think that we being, everyone who cares about healthcare, really push for more race-conscious models? And are there any potential pitfalls to that?
I mean, the way that I think about this is that, going back to how I started, science and medicine has been complicit in the creation of racial categories, in the justification and endorsement of racism. And so given this history, there's a responsibility on the part of these fields and these professions to address what they have created. We're not asking people to, step outside of their lane, but to acknowledge their lane and to say this is what the legacy that you're professionalized into, and you have a responsibility. And there are, especially a younger generation, really taking this seriously. And again, thinking about the way forward, one of the organizations that really inspires me is called White Coats for Black Lives, an organization nationwide with chapters in different locales. Medical students started around 2014, 15, and asking the simple question, like, is medicine responsible? Are we responsible to help address racism? And their answer was an emphatic yes. And I'll say one of the things that I love that they do a number of things. Again, go to their website, but they issue report cards on medical schools. So they grade medical schools along a whole host of factors in terms of the pedagogy, what they're learning, how they're interacting with communities and clinics, who the faculty are, a whole host of factors, 30, 40 parts of the measurement. And then medical schools get A minus, B plus. You can see what your medical school, where you stand. And it's useful, I think, on the part of incoming students to think about what to expect, where you want to go. But it's also a form of, what they say, what you count, you can't hold people accountable unless you count it. And so to think about what needs to change is different forms of accountability. And this is the students saying, we're not just consumers of the education you give us. We have a right and responsibility to also speak back and talk about how we don't feel equipped to be physicians and to be healthcare providers based on what we're being taught right now and how we're being taught. And so that's one example of, I think, an ownership for this problem that I think we can build on.
So thus far, in my thinking has largely been focused on sort of how technology, let me say specifically AI and machine learning, are flowing into how individuals receive care. But another area that we took a close look at in terms of the potential, asterisks, of AI was even on population-based care. And I want to raise that because it's a really important part of the healthcare system. And just to give a little background, when we did our series, I spoke with Dr. Vindell Washington, and he's currently CEO of Onduo. It's a Verily company, and they're developing a population-based care tool to help people manage their diabetes, mental health, et cetera. He's a Black physician, and he told us that specifically, like, he wants to develop tools that can be used well outside of the doctor's office, because so much of what determines health outcomes happen far away from the touch points of healthcare itself. And so, there are tools designed to collect data wherever you are, whenever you are, what your glucose level is at that moment, what you've eaten, how you're feeling, et cetera, et cetera. Okay, now the reason why I just wanted to lay that out there is what this could potentially really help a lot of people who, first of all, have a difficulty accessing healthcare, but could there also be some risks to this sort of wider net that AI could potentially cast over people's lives?
Yeah, absolutely. I mean, I haven't read firsthand, just based on the description. One of the antenna that goes up for me is that wide sweep of data collection and the fact that we don't have many protections around data privacy, if any. And so, the idea that what you have access to has access to you. So you're giving away all this data for this do-gooding, under this do-gooding sort of umbrella, but where that data is going, who's going to use it, any firewalls. I know of an example that I talk about in Race After Technology of an advocate, a data privacy advocate and data rights advocate in Europe who was she had a health condition, I think a brain tumor, and she went to a bank to get a loan, and the bank had access to her health records and denied her a loan, even though high credit, high income, Exactly this idea of data sharing, one of those buzzwords that sounds good, but if different entities are sharing your data that you might not want it to be shared, then, and we don't have protections around that, there are a number of red flags to go off or specifically around that description. But then, in addition to that conversation about data privacy and data rights, is just the whole idea of population health, generally speaking, and what we know about the history of population health is that although there can be wide overall general improvements to population health, that can go hand in hand with increasing disparities across groups. So those two things often happen at the same time. The overall health can generally increase and disparities can increase at the same time because those improvements are not benefiting all groups the same. That prior forms of inequity get reproduced in who gets access to those new health goods. There's a great article that summarizes this. The title is Controlling Disease, Creating Disparities by Phelan and Link at Columbia, 2005 paper that just outlines something that when I say it out loud, you say, oh yeah, that makes sense, that you can get new good things, but then everyone doesn't get access to it, so the disparities increase. So with something like this, it can have a good intention behind it, but if those who are implementing it aren't thinking about the existing inequities in society and how that particular intervention or goods is going to impact different groups, it may end up increasing disparities overall.
Yeah, we're going to move to some audience questions in just a couple of minutes, so keep sending them in, everyone. I just want to wrap up this portion with a little bit of personal cynicism because of a fundamental truth of what the American healthcare system is, which is a for-profit healthcare system. Because one thing that I came away with when we did, we were doing months of research to do this AI in healthcare series, was that incentives matter. And this is a really big question with no one particular answer, but I just want to put it out there, that as for all things tech and all things healthcare, it's kind of like supercharged when the two meet, that you have to question what are the incentives that are driving the development of certain technologies. And it just doesn't seem to me that we have a system in place right now that has the incentives built in to develop technology with the other competencies that you talked about in place, or that could have a widespread positive effect on people outside, say, high cost, high value hospital applications. What do we do about that?
I mean, the questions that we're talking about AI and healthcare, it relates to this broader conversation about a profit-driven system, right? And so I think we can't isolate the inequities that are reproduced with AI without thinking about the underlying incentives and economic structure. And at the same time, to note that inequities can exist even if even if there's universal coverage. That we can't simply legislate away or just address the economic sort of model without also thinking about the everyday practices that can still reproduce inequities. And so we have to chew gum and walk at the same time. We have to think about the economic context and really think about what universal access to healthcare should be without this profit-driven incentive. But at the same time, know that that's not the end of the story. By just addressing that is not going to magically sort of address the racial inequities that can still be reproduced in informal ways, even if the formal structure seems more equitable.
Yeah, point well taken. And in fact, one of the first questions from the audience is jumping off from that. This was submitted in advance, actually. What are the safeguards we can put in place to ensure equity when developing this technology?
Yeah, so we're, again, still in the early days of reining in what some people call the wild, wild west of tech and AI. And so in the last few weeks, some of you may have been following what came out of the Office of Science and Technology Policy at the White House, which was a blueprint for an AI Bill of Rights. That I think is a really important starting point. It lays out 5 principles that should guide our thinking, whether AI in healthcare or other domains, a handbook that gets us to think about how to translate those principles into practice. And so for anyone who wants to dig into that, I think that that's an important starting point. There's also an algorithmic accountability bill that was reintroduced earlier this year by several senators that, again, is trying to think about what protections should look like. I think the main point is that those who are producing these technologies can't be left to govern themselves and to create their own in-house ethics councils, as many companies have tried to do, and sort of domesticate the critique in that way. It has to be more independent oversight and eventually legislation with teeth that can intervene when harms are enacted, which they already have, as your healthcare example points. Millions of patients have been affected by that particular healthcare algorithm with that disparity introduced. And so we are, in many ways, having to deal with the harms that have already existed and think about what a more preventative, proactive policy context should look like going forward.
So again, we've got a good flow now going. With this idea of like, what can we do? Someone from the audience is asking, we test, this is something I've wondered about as well, so whoever asked this question. We test medicines for efficacy and side effects before marketing.
Yes.
Right? Do you see a role for algorithmic regulation in health?
Yes, absolutely, big yes. And there are people working on this, so there's the testing part, but there's also some interesting work done around having labels for data that they're kind of corollary, like we have on food labels to tell us what's in our food, with data and data sets to have nutrition labels for data that indicate the kind of biases that come from the training data and the data sources, to just make things more transparent and apparent so we can evaluate them more effectively. The only reason we know about that particular healthcare algorithm case is that company allowed the researchers to audit and to study it. Otherwise, it would still be, being used without any notice of that particular harm associated with it. And so the kind of black boxing, as we call it, of these algorithms and these data, we have to really dismantle those black or anti-black boxes, as I think of them, and find ways to make it more auditable and transparent.
Yeah, it's interesting because, of course, the basic data used to train these algorithms is also a huge part of this issue more broadly. I didn't actually specifically ask you about that, but someone from the webcast is wondering, if we start from the perspective that the data we have available to build AI models is inherently flawed, in that not everyone has equal access to healthcare, how far out from representative data are we?
I can't really answer that in the abstract because I think it's specific to whatever the data set and the context is, but I do think that there's a role for, in any design process, to step back and ask what data is missing and how might that impact or lead to particular biases. And so I was reading recently about how such a high percentage of heart attacks are silent heart attacks that people never even end up in the hospital, but there's all these downstream adverse effects associated with. So that health experience will never show up in a record that can be used to train an algorithm to then monitor for those signs. And so that's a case of asking what is missing from this data and how can we potentially find a way to account for it in the process.
Yeah, I'll give you another example of that. I had mentioned earlier about the tool that's used at Stanford Medical Center. It was, it was trained on countless healthcare records that came from Stanford Hospital and Lucile Packard Children's Hospital. So it serves Silicon Valley. Now, the question in that case is, if they want to sell this tool to other hospital systems or other parts of the country where the patient population is quite different, would that tool actually even be effective in helping the patients in those other parts of the country or other systems? I mean, and that's something that the developers there are grappling with, but it gets back to this question of
context.
Context,
Absolutely.
yeah. And how we need to be very intentional and thoughtful at every step of the way to pull that context in. So I might have already asked you this, but maybe I just want a little bit more from you. Do you have any further like practical ideas or points in the system where you would say, here's definitely a place that we should be working harder to get those cultural and social competencies in as like a regular part of how we develop these technologies?
Yeah, I mean, in some ways, I think at every stage, but I think it's especially important at the conception, at the starting point, when we're setting up our team and thinking about what forms of knowledge should be around the table and is relevant to this. I think these issues and questions are too important to leave it to those who only have the technical expertise, or even those who have a narrowly defined ethical expertise. And so thinking about what sort of suite of disciplines and knowledges do we need around the table, I think is crucial. Practically speaking, there's a great set of principles that I would offer in addition to the Blueprint for AI Bill of Rights called the Design Justice Principles that I think are 10 or 11 principles that lay out almost like a checklist that you can think about in terms of, have we accounted for this? Have we accounted for that? And perhaps not all of the principles will be relevant to any specific project, but I think it can offer a kind of rubric for individuals or groups to think through, have I thought of this? Have I missed this in the process?
So we have an audience question here. Oppressed patients may be reluctant to share data. So going back to the data question, what can we do to build trust with patients that have historically been penalized by sharing data about themselves?
Yeah, thanks for that question. I love questions of trust because it gives me an opportunity to say that I prefer to frame the issue as an issue of trustworthiness on the part of institutions. So rather than think, how do we win the trust of this community or this patients, how do we foster the trustworthiness of these institutions that have a track record of harm and mistreatment? And that Healing Arc initiative offers one example of how that could happen, how to actually partner meaningfully with communities who you may want to, whose data might be meaningful, whose involvement, whose insights you might want. One particular line stands out from the very first study that I did as a graduate student around biotechnologies in California. An individual who I was speaking to said, why am I in such demand as a research subject when no one wants me as a patient? Why am I in such demand as a research subject when no one wants me as a patient? We might amend that. Why is my data so valuable when no one wants me as a patient? And so thinking about the kind of what we call predatory inclusion, we want to include people when it suits us in the institution as researchers or as clinicians, but when it's important for the community or the patients in terms of the standard and the quality of care, then there's so many shortcuts. There's so many ways in which people fall through the cracks. And so thinking about that, the kind of reciprocity that needs to be established and trustworthy that needs to be fostered, I think is a starting point when we think about data, when we think about clinical trials or anything like that.
So another question here from the audience. What are your thoughts on automated mental health care for people of color? Thinking that the therapy chatbot assumes a neutral voice, but usually neutrality is equated to whiteness.
You know, I haven't thought a whole lot about this specifically, but I would want to unpack, what are the assumptions that are going, not just in the voice of the chatbot, but even in what signs are used to diagnose different conditions, and how that has been racialized, going back to Jonathan Metzl's work, a different book altogether, Protest Psychosis, looks at the way that anger and agitation among Black folks has been pathologized in the wake of the civil rights protests in the 60s and 70s, and how diagnoses of schizophrenia were attached to Black men in particular to pathologize the rightful anger around our social situation. And so I would want to think through the assumptions and the meaning of various kinds of behaviors and disorders in the process of thinking about that.
Yeah. As we unfortunately move toward the end, these things always come to a close too quickly. We have a question here, and then I have just a follow-up about I like to give people tools on what they can do. So we have a question from the webcast specifically about how can we be better data activists to collect more representative data that creates more generalizable models?
Yeah, that's a good question. And I think the first part of it, there's a lot of ways to answer what individuals can do. My go-to wouldn't necessarily be to think about how to collect better data as the place that I would start. I would think about how the tools that are already being rolled out and impacting all of the algorithms that are already shaping our opportunities and our experiences, how we can begin to address the harms associated with that. So a very local example of that right here in New York City, called the Coalition to End Racism in Clinical Algorithms, whatever that acronym is, someone figure it out, but Michelle Morse here in New York, who's also one of the founders of Healing Arc, has helped to develop this coalition only in the last year. And I would encourage people right here in the city to find out more about it and think about how you can support something like this.
Slight tangent from the audience. Someone wants to know what is most rewarding about introducing social change into your pedagogy?
Well, it was mentioned earlier that I work with the Ida B. Wells Just Data Lab. So these are undergraduate research associates who partner with community organizations on a whole host of projects that are defined by those organizations. So we're not researching communities, but we're partnering with them around the data justice projects that they want us to assist with. And so overall, that brings a lot of joy and fulfillment to see the next generation of scholars and activists understanding that they don't have all the answers, but they can put their energy and their sort of insights and skills at the service of these larger movements. And so it's sort of staging those collaborations is really meaningful.
So another one from the audience. Now they're all rolling in. This is good. This is good. You mentioned the role of responsibility in the discussion. Are you willing to allocate responsibility to a robot or AI? If robots are not responsible for being, now the question has disappeared there. No, that question. I think I think the question was going in the direction of who should be responsible for, especially when we move towards even more aggressively, I'd say machine learning and AI will try to make predictions on people as well. But
yeah, I think that there's responsibility to go around. I definitely think that the people who both create it and also implement it in any context are responsible in different ways. And there should be mechanisms in the same way that if a car malfunctions or something else that we create and put out into the world wreaks havoc, we need mechanisms to figure out how to hold individuals, companies, organizations accountable for that. And so I think the same applies here.
Yeah. So I guess finally, we've been talking a lot about what can be done sort of internally in the world of healthcare, in the world of tech, and policy, and in the world of policy. What's the public's role here?
Yeah. And so, there's no general public for which I can prescribe one set of marching orders. I think part of what we should think about is how these systems are impacting where we are, our place of work, our field, and to think about whether or not there are ways to create accountability and to create a different approach to these tools that are informed by the issues that I'm raising, the sort of social histories behind them. And so one is to think about our own locale, diagnose a kind of social autopsy, but also I think in a diffuse sense, in terms of a cultural awareness, I think one of the things we can all do is to demystify technology and AI and to sort of move beyond the marketing hype behind them and to say, okay, we're talking about math here. And not to buy into the buzzwords and the sort of, the ways that they're sold to us. I think that's part of a cultural shift where we together demystify it. And in that sense, we also gain more collective ownership around who gets a say in this. Because to the extent that we mystify it and put it in a little box that says this is asocial, apolitical, only those who have this very narrow technical expertise can weigh in, that means that there's no democratic process or participatory process for us to be able to deliberate about how these things are impacting our lives. And so I think part of that is a cultural shift that we can all play a part in and check each other when we begin to get wrapped up in the kind of marketing speak of AI.
So can I just ask for a little bit more on that? Because I think the demystification is vitally important. Are there practical ways of doing that? Like maybe regulating more transparency into the process so that for as long as there aren't more voices at the table, say at the genesis of these projects, at least others can come, that we can have more analysis like the Obermeyer paper. I mean, this is not a solution per se, but a step towards a solution.
Absolutely, and if I can put you on the spot, I will say investigative journalism is crucial to this demystification. I specifically, if you look at the citations of Race After Technology, I'm mainly relying on people like you, people at ProPublica, people at all of these outlets that have done these deep dives before the scholarly texts have come out. And so I think that that's been a crucial role in terms of our general public awareness around that. So thank you for your work.
Well, now we don't want to go down the tangent of how media could be doing a much better job in terms of journalism that actually serves the public good. But I'm going to sneak in another question here because, talking about making change where we are, someone's asking, while training students to analyze data, it can be difficult to avoid data sets that are old, as old as some of the examples we've talked about, and some of those older data sets very much reflect racist practices, such as redlining. So this person is wondering, what training do faculty need to better able to address this?
That's a good one. I think, I think it's hard to place it on the shoulders of any one faculty member who might be teaching a course, but this might be a good instance of bringing in people from different departments to unpack. And I think those older data sets actually provide an opportunity, again, how they can shine a light on these existing practices that might have been shrouded in mystery before, and really using examples that are directly impact students. And so one that comes to mind that some journalists at The Markup published in the last year and a half looked at something called student success predictor scores that are used by over 500 colleges and universities across the country, again, to figure out how to intervene early in students that might need help, right? So it attaches risk scores to students, low, medium, and high, to say whether you're likely to drop out. And what it found was that it predicted that Black students were higher risk, much more on average, much more than their white counterparts, and Black students in STEM fields were labeled high risk. And so it found this racial disparity and yet this thing is being used across the country. And so this gives us an opportunity to think about what's happening here. And going back to my earlier provocation, that what if instead of predicting the riskiness of individual students, we turned it back on the departments and the schools in which students are navigating and say, why is economics so high risk for women? Why is biology so high risk for Latinx students? And so it's a way of taking this data and these models and saying, rather than look at those who are just trying to navigate these institutions and trying to figure things out, why don't we look at who and what is producing risk to begin with? And so even though this is under the rubric of helping students, it actually is can be another kind of racial steering tool, like we see in the housing market, in which an advisor sits behind a little screen, student sits down, you get a high risk score, and you say, maybe you should think about switching your major. You're not likely, if you stick in this major, you're not likely to graduate. And so it gives a kind of, a data justification where it's not me, I'm not a racist or sexist advisor. It's the computer telling me that they're not going to graduate. And rather than think about what we need to do to change the environment in which young people have to work.
That actually just gave me pain thinking that's happening to young people. Gave me actual pain. So here's another question. We must be more rigorous in how we think about and deploy these tools, because I'm just getting distracted because that is such a potent example. I mean, like you're right. No one in those scenarios you're talking about does not want that student to graduate. Yeah. And in fact, that's part of what would be driving them to provide this terrible advice on, like, go to some other field where you're more likely to graduate. We're all part of the system, so we have to check ourselves here. Okay, so here's another question that actually came in advance, but it's a good one because we have been focusing very intentionally on the US context, but someone is wondering, is racism in medical AI a global phenomenon?
I think on one hand we could say yes, but I think the social categories that are most salient in any region or any country should be what the focus is. And so it might be caste and religion in one place. It might be color hierarchies in one place. It could be socioeconomic, cross-cut with another category. So part of it is not for us to just take one sort of rubric or set of questions and export it everywhere, but for researchers and advocates in different locales to ask themselves, what are the salient social categories that are determining life chances and opportunities in this place, and how might that be encoded into the systems and the technologies that are being produced? And so it's that more contextual approach that I would advocate.
It's bringing in those complexities from the start,
yes.
Right? Yeah. Someone in the room has a follow-up. I'm hoping it's for you and not me, because it says, how could media do better here?
Tell us.
Do you really want me to answer that? Well, first of all, we have to care. I mean, I think we have to care. We have to, I raised the incentives question to you earlier because I think it matters in every field, and I think there's just a lot of perverse incentives in journalism right now that draw good people away from doing reporting that can actually serve the public good. I'm blissfully mostly insulated from that, being in the public media sphere. But as much as I'd like public media to have the impact that some 5-minute garbage piece on CNN has, we just don't. So I don't know how we change incentives in the for-profit media sector, which is like most of it, in order to actually, again, there's good people. It's just that decisions made above them force their coverage in a certain direction. That's where I would start. There's a lot more. I mean, I think there aren't enough people with science and medical and sociological backgrounds in journalism, people with content knowledge outside of journalism, so that they know even what are the areas that we should be looking at. Again, issues of representation in journalism, across the board. But I really think the incentives matter, because when it's a corporate media structure, ultimately the bottom line will be what determines it, and the bottom line is driven by clicks and eyeballs, unfortunately. So, but I don't give up hope, though. I do not give up hope. Just as I don't give up hope with the potential, again, for well-designed, culturally, socially, historically competent technology in healthcare. And I really am going to wrap up this with this question. I don't hear you coming off as a techno-skeptic, which I'm kind of glad about, but am I hearing that correctly?
I think partly because that also gives too much power and autonomy to technology. It presumes that technology is creating the problems rather than the human beings behind it. And so that is another way of saying that this technology has a mind of its own. No. It's the people, it's the society in which it's developed that we need to go behind the screen and think about. And so I'm less focused on how do we tweak this algorithm to make it less biased than what is the institutional or social context in which this is being developed and implemented, and how can we get more to the roots of the issues. And for me, one of those roots is the training of the next generation of not just technologists, but citizens and people who are going to engage in these systems. And so I think partly my general optimism is the fact that I get to have a direct sort of engagement with the people who are coming up. And I see that they powerfully combine both a critical and creative approach to technology. That means a greater awareness about the social and historical context, but also not just ending with the critique, but thinking, how can we do things differently? How can we design with different values? How can we engage communities in a more reciprocal, equitable way? And so part of it is that I'm immersed in that space of young people who have those two sensibilities, that it kind of washes over me.
So I'm hearing you saying that you are optimistic about what's possible.
I guess so. If I have to lay claim to a word, sure.
Well, Dr. Benjamin, this has been inspiring and eye-opening and grounding as well. And I cannot thank you enough for your work and for being part of tonight's conversation and for giving us things to think about and do in all of our spheres regarding this very, very important issue. So thank you so very much.
Thank you.
And thank you again to the Greenwall Foundation and for everyone coming here tonight and who watched online. I hope that we did give you something to think about. And again, we're all about trying to get people to be active participants in these issues. So I hope you take it into your various fields. Thank you again tonight.
Thank you.